Bismillahirrahmanirrahim. Quote for today is sometimes it takes a good fall to really know where you stand. Today the topic of my presentation is diphtheria and I am presenting it under the supervision of my professor Dr. Saira Afsal. Learning outlines of the presentation are introduction of diphtheria, epidemiological triad, chain of transmission, levels of prevention, recent advances and MCQs at the end. Learning outcome. By the end of this presentation, participants will be able to describe about diphtheria, mode of prevention, treatment, recent updates, and MCQs at the end. Introduction of diphtheria. Diphtheria is a bacterial infection caused by Bacterium diphtheriae, are transmitted from person to person through close physical respiratory contact. It can cause infection of the respiratory tract, throat, nose, and larynx, local production of false membrane with the release of exotoxins, which may lead to breathing difficulties and death. Now, background of the disease. Diphtheria is a bacterial disease that has long history from its first description in the 5th century to the development of an effective vaccine in 1920s. Hippocrates described diphtheria in 5th century. The disease was a major threat to children and was associated with the poor. In 1826, however, the disease was given its official name diphtheria, which comes from the Greek word leather or hide. In 1974, WHO included diphtheria toxoids in its list of recommended immunization. However, in 2004 to 8, no case of diphtheria was recorded in the United States. It mostly occurs in winters or spring, and it is communicable for 2 to 6 months without antibiotic treatment. Now, occurrence. It is prevalent throughout the world. It occurs in temperate zone. Epidemics are usually local and not widespread. In countries where effective primary immunization practice, it has become rare. Now I will tell about the epidemiological triad, that agent, host, and environmental factors that influence diphtheria. Agent factors. Bacterium diphtheriae or Klebsiella bacillus. It is a gram-positive, club-shaped that is comparable with the Chinese letter L and V. It is non-motile, non-encapsulated, non-sporulating, gram-positive rod. It has 4 biotypes: gravis, intermedius, mitis, and belfanti. All biological types can become toxigenic and can cause severe disease. Host factors. Children of age 1 to 5 years, both genders, low socioeconomic status, and infants are immune till 6 months of age because of maternal antibodies. Environmental factors are mostly winter and autumn and overcrowding. Chain of transmission, it is usually caught by coming into contact with droplets from the respiratory tract of an infected person, particularly spread by coughing or sneezing. This slide shows the pathogenesis of diphtheria toxins, that how it transmits and enters the membrane of cell and causes cell death. Source of infection is nasopharyngeal secretions discharged from the skin lesions, contaminated fomites, and infected dust. Mode of transmission is direct and indirect. Direct mode is by infected cutaneous lesions and droplet infection, and indirect is fomite borne. A portal of entry can be of respiratory route, non-respiratory route, cuts, wounds, ulcers, and umbilicus in the newborn. Now, period of communicability. 14 to 28 days from the onset of disease, and carriers may have much longer time. Incubation period is 2 to 6 days for the disease. Regarding pathogenesis, bacteria multiplies in throat and releases powerful exotoxins, which is responsible for the formation of grayish or yellow membrane all over tonsils, pharynx, and larynx with well-defined edges and cannot be wiped away. Marked congestion, edema, and local tissue destruction, enlargement of the regional lymph nodes, signs and symptoms of toxemia. These are the images that are shown of the patients that are having diphtheria. Now, clinical types, there are four basic clinical types. Pharyngeal diphtheria. Early manifestations are mild sore throat, fever, malaise, membrane formation, stridor, dysphagia, enlarged cervical nodes, producing a bull neck and toxic look. Laryngeal diphtheria. It is usually associated with the pharyngeal diphtheria, may be primary or without membrane. It's a clinical feature of hoarseness, cough, stridor, and restlessness. Cyanosis and death usually occurs due to suffocation. Nasal diphtheria. Chronic, serious, or seropurulent discharge, crusty exudated around the nose, foul odor, white membrane on the nasal membrane. Cutaneous diphtheria. It is also called as desert sore, chronic tropical ulcer, punched out ulcer, and it is not very common. Now, there are remote effects of diphtheria toxins. It can cause cardiac toxicity, that may be myocarditis due to direct toxin damage to heart muscles, arrhythmias, heart block, and heart failure. Neurological effects are cranial nerve palsies leading to vision, swelling, and speech difficulties, respiratory paralysis from phrenic nerve involvement. Renal damage. Acute tubular necrosis due to hypoxia or direct toxin effects. Proteinuria and oliguria that indicates kidney dysfunction. Endocrine and metabolic effects. Potential adrenal gland involvement impairing stress response. Disruption in the glucose metabolism and electrolyte imbalances. In respiratory complications, laryngeal edema or bronchopneumonia secondary to systemic effects. Risk of airway obstruction exacerbated by toxin spread. Delayed healing and tissue recovery. Impaired regeneration of affected tissues due to ongoing toxin interference. Long-term complications like persistent weakness or chronic fatigue. Primary immunization. Primary prevention of the disease by ensuring high population immunity through immunization. Then comes the specific protection or immunization. Diphtheria toxoid. The toxoid is grown in liquid medium from toxigenic Corynebacterium diphtheriae. It is available in combination with pertussis and tetanus vaccine. It gives clinical efficacy of about 97%. Local reaction like arrhythmia is common. Should be stored at 2 to 8 degrees Celsius. Frozen vaccines should never be administered. Routine schedule. Primary dose age of 2 months, an interval should be none. Second primary at the age of 4 months. Uh, Primary dose of 3 at the age of 6 months, and then comes at the age of 15 to 18 months. Diphtheria, tetanus, toxoid, and acellular pertussis vaccine is a vaccine of choice for the children 6 weeks through 6 years of age. If child has valid contraindication to pertussis vaccine, then pediatric DT should be used to complete the vaccination series. If the 4 doses of DT, DTP, or DTF are administered before the 4th birthday, a booster dose, 5th dose, is recommended at 4 through 6 years of age. This table shows childhood immunization schedule for diphtheria, tetanus, and acellular pertussis vaccine. 4 to 6 years of age, before entering school, a booster of DTF is given. Another is given at the age of 11 to 12 years of age. It is a booster immunization. Every 10 years thereafter, tetanus toxoid is given and it protects adults. This slide shows that people of all ages need diphtheria vaccine. This slide shows EPA schedule for Diphtheria, tetanus, pertussis, bacteria, when to given and at what weeks. Now the secondary prevention of the disease. Secondary prevention of the spread by rapid investigation of close contacts to ensure the proper treatment. Diagnosis is mostly clinical. Simple throat smear should be examined. If diphtheria-like organisms, culture should be obtained. Administration of antitoxins without waiting cultural report. Schick test. Immunity to diphtheria can be determined by Schick test. It is useful for detecting persons at high risk, such as physicians, nurses, and hospital staff. It's an intradermal test. It depends on the fact that toxins exert local destructive or irritating actions on tissues. Zero point 0.2 ml of the Schick test toxin is injected into the skin of forearm as test, while 0.2 ml of inactivated toxin is injected on the other forearm as control. Now the interpretation of results. Positive interpretation is circumscribed area of redness up to 3 centimeter or more in diameter within 24 to 36 hours and maximum by 4th to 7th day on test arm and control arm has no change. So this shows susceptible to diphtheria. Negative reaction, both arms are without reaction, so person is immune. Pseudo-positive reaction, red flush appears on both arms but fades within 4 days. Allergic type of reactions, Schick negative. Combined reaction is true arm shows true positive and control arm shows pseudo positive, that is susceptible to diphtheria. Control and treatment. Early detection of cases and carriers, isolation and treatment. Antibiotics are not useful in acute infections. However, antitoxin is a must and primary concern. Antitoxin obtained are from the age of dose of 20,000 to 40,000 international units are administered. These are the different antibiotics that show that sensitivity are shown. However, the most sensitivity is shown for erythromycin. Control of patients. Notification to local health authorities. Isolation imposed unless 2 consecutive cultures from the throat and 2 from nose and 24 hours apart fail to show virulent diphtheria bacilli. Now, what is a probable case of diphtheria? A probable case of diphtheria is a case that meets the clinical description of an illness that is characterized by laryngitis or pharyngitis or tonsillitis and by an adherent membrane of the tonsils at the pharynx or nose. What are cases? Diphtheria antitoxins should be given without delay intramuscularly after giving 0.25 ml Schick test as a test dose, subcutaneously, and in mild cases 40,000 units, in moderate cases 80,000 units, and in severe cases 120,000 units should be given subcutaneously. Benzyl penicillin 2.5 lakh units every 6 hourly or erythromycin 250 milligram every 6 hourly for 5 to 6 days. Carriers erythromycin 250 milligram every 6 hourly for 10 days. In context, if primary immunization or booster within previous 2 years, then no further action should be required. If primary immunization or booster dose of tetanus diphtheria toxoid more than 2 years before, only booster dose of diphtheria toxoids. Non-immunized close contacts should receive prophylactic penicillin or erythromycin with 1,000 to 2,000 units of diphtheria antitoxin and actively immunized against diphtheria. Contacts should be examined daily for 7 days for any evidence of diphtheria. Active immunization with diphtheria of all infants with subsequent booster doses every 10 years thereafter should be given. Institutional control. In case of diphtheria breakout in close community like boarding houses, orphanages, juvenile jails, schools, hospitals, the whole community should be actively and passively immunized with refined antitoxins in one arm, that is 1000 to 1500 units for adult and 750 to 1000 units for children intramuscularly or 0.5 cc of APT in the opposite arm subcutaneously at the earliest opportunity. The antitoxin provides temporary protection that lasts for about 2 to 3 weeks. After this, take throat swabs for the entire population and segregate all throat swab positive for 15 days because this is the time when positive immunity, which lasts only for 15 days, fades away, and active immunity starts developing. After this period of 15 days, the active immunity will rise sufficiently to protect the inoculated person from the risk of infection. Tertiary prevention. Tertiary prevention of complications and deaths by early diagnosis and proper management. Now coming towards the recent advances. This slide shows the WHO recommendations. WHO recommends the surveillance of diphtheria consists of routine monthly report of probable or confirmed diphtheria cases and immediate investigation of all diphtheria outbreaks with the collection of case-based data. Monitoring the number of infants who have received the third dose of diphtheria toxoids containing vaccine is also important. In countries with low incidence, immediate reporting of case-based data of probable or confirmed cases is recommended from peripheral level to intermediate and central levels. Another article published is Diphtheria, the rising cases of throat distemper in Pakistan, a communication. This shows the data on the diphtheria cases were collected from various sources, including Pakistan Ministry of Health, the WHO, and media reports. Descriptive statistics were used to summarize the data on the number of cases and trends over time. As of 2030, the number of reported diphtheria cases in Pakistan has increased by 50% compared to previous year. The majority of the cases are being reported from the Sindh and Punjab province, and the incidence of diphtheria is highest among children under the age of 10. Another article that is systematic review shows what is the true burden of diphtheria, tetanus, and pertussis in children aged 3 to 18 years. This shows that the true burden is unknown because of the weak or absent nationwide surveillance system. The available evidence highlights the inadequacies in immunity either by gaps in recommendations. UNICEF shows that at least 80 million children under 1 are at the risk of disease such as diphtheria, measles, polio, as COVID-19 disrupts routine vaccination efforts. This is warning given by the Gavi, WHO, and UNICEF. Now, the agenda explaining immunization agenda 2030. 84% of the children received all 3 doses of the primary series of diphtheria toxin in 2023. Targets to be achieved by 2030 include achieving 90% coverage for essential vaccines given in childhood, halving the number of children completely missing out on vaccine, and completing 500 national or subnational introductions of new or underutilized vaccines such as those for COVID-19, rotavirus, or human papillomavirus. Immunization Agenda 2030 seeks to create a world where everyone, everywhere, and at every age fully benefits from vaccine for good health and good well-being. Now coming towards the MCQ session. First MCQ is an XYZ patient is admitted in the hospital with the suspicion of diphtheria and proper isolation is also done, but the incubation period of the disease passed and there is chance of spread for the close contact. What is the recommendation of immunization for close contact? Option A, if primary immunization or booster within 2 years, no further action is required. Option B, if primary immunization or booster within 3 years, no further action is required. Option C, if a primary immunization or booster within 4 years, no further action. Option D is if primary immunization or booster within 5 years, no further action is required. Option A is the right one. Second question is, an XYZ patient presented in the ENT OPD with the complaints of fever, sore throat, and pain on the swallowing. After examining, doctor confirmed the diagnosis of diphtheria. The isolation period recommended for this patient is still option A, complete blood picture becomes normal. Option B, two consecutive negative throat and nasal swab cultures. Option C, negative chest radiographs. Option D, after completion of antibiotic course, and ease after completion of the symptoms.
B.
After, option B is the right one, two consecutive negative throat and nasal swab cultures. Third MCQ is, a person underwent Schick test and throat culture for diphtheria. It was revealed that he is Schick negative, but throat culture is positive. So he is option A, patient, option B, carrier, option C, immune, option D, susceptible, and option E, sick.
C.
Option A is the right one, he is the patient because throat culture is positive. Fourth MCQ is, 8 years old boy presented in the OPD with the complaints of fever, sore throat, and difficulty in swallowing. On examination, there is a membrane formation at the back of throat and enlarged cervical nodes producing a bull neck appearance. This is option A, pharyngeal diphtheria, option B, laryngeal diphtheria, option C, nasal diphtheria, option D, cutaneous diphtheria, and option E, nodal diphtheria.
Alpha.
Alpha.
Yes, option A is the right one. Fifth MCQ is, a 10 years old child was tested for diphtheria. His throat swab was taken and Schick test was performed. Final results were that his throat culture was negative while his Schick test was strongly positive. On the basis of these results, he is option A case of diphtheria, option B, immune to diphtheria, option C, carrier of diphtheria, option D, susceptible to diphtheria, and option E, sick of diphtheria.
Charlie.
C.
Option D, susceptible to diphtheria. Sixth MCQ is, an XYZ patient presented in the dermatology OPD with the chronic tropical ulcer. On examining, the ulcer is punched out in characteristics on the arm of the patient, which is the type of diphtheria according to the statement. Option A, pharyngeal diphtheria, option B, laryngeal diphtheria, option C, cutaneous diphtheria, option D, nasal diphtheria, and option E, ulcerative diphtheria.
Charlie. C.
Yes, option C is the right one. Seventh MCQ is, a patient is admitted in the hospital with the diagnosis of diphtheria. Patient facing the problems of restlessness and difficulty in breathing. On 14th day of admission, patient was expired. Which type of diphtheria is fatal? Option A, pharyngeal diphtheria, option B, laryngeal diphtheria, option C, cutaneous diphtheria, option D, nasal diphtheria, and option E, ulcerative diphtheria.
Beta.
B.
Yes, option B is the right one. Laryngeal diphtheria is the most fatal one. Eighth MCQ is, diphtheria is a bacterial infection that is caused by the Clostridium bacterium, Corynebacterium diphtheriae. It is transmitted from person to person. Which of the following age groups is mostly affected by diphtheria? Option A, 1 to 5 years. Option B, less than 6 months of age. Option C, greater than 65 years of age. Option D, women of reproductive age. And option E, newborn baby.
A.
Alpha.
Yes, this is the right one. Ninth MCQ is, diphtheria vaccine consists of the diphtheria toxoid available in combination with pertussis and tetanus vaccine. Which of the following is not true about the vaccine administration? Option A, people of all ages do not need diphtheria vaccine. Option B, it is vaccine of choice for children under 6 weeks through 6 years of age only. Option C, booster Tdap is given at 11 years. In adults, booster dose is given at every 10 years. And option E, diphtheria vaccine is not required in areas with recorded cases in the past decades. Option A
Beta.
is last MCQ is there are multiple combinations of vaccines which are used to secure the child from three diseases like pertussis, tetanus, and diphtheria. Which combination is used in infants' age group? Option A, diphtheria toxoid and activated pertussis vaccine. Option B, diphtheria toxoid. Option C, diphtheria and pertussis. Option D is activated pertussis and tetanus toxoid. And option E is only tetanus toxoid.
Alpha.
A.
Yes,
Alpha.
in infants, this
Alpha.
group, yes, this is the right one. This is the key of MCQs. This is the YouTube channel where you can find the presentation. And thank you.